Good morning, sir.
Yeah.
Sir, I am Dr. Arun Raja from Tanjore
Good
Medical
morning,
College.
everybody. Today, Arun will be presenting, and it will be moderated by Professor T.D. Yadav and Professor Naimesh, and then we have Professor Anand who will be joining us shortly. And it's all yours, T.D. and Naimesh. You can take over now.
Sure, thank you, sir. Can we start, Dr. Arun?
Yes, sir. Good morning, sir. Good morning, respected sirs. Thank you for the opportunity given. So, here I am presenting a case of a 64 years old male who is a resident of Telangana and farmer by occupation. Has come with chief complaints of right upper abdominal pain since 4 months, an episode of loss of consciousness 4 months back, and generalized weakness and giddiness since 4 months. So, history of presenting illness. Patient was apparently all right 4 months back. Then he developed a right upper abdominal pain, which is gradual in onset, mild, dull aching, and continuous type of pain. It is non-radiating, not related to food, and not associated with any aggravating or relieving factors. Patient also gives history of an episode of loss of consciousness for 5 minutes. After that, he recovered promptly. Post-episode, patient recovered in full without any weakness, memory loss, neurological deficit, or injuries. Patient developed generalized weakness, making him unable to continue his day-to-day activities since 4 months. So I would also like to know whether the patient is having any history of easy fatigability and shortness of breath and symptoms of anemia. He also gives history of loss of appetite and unintentional loss of weight of about 5 kgs in 4 months. And there is no history of fever, jaundice, hematemesis, melena, nausea or vomiting, and dyspepsia, postprandial fullness, or early satiety. And there is also no history of altered bowel habits or chronic drug intake. And there is no history of any previous blood transfusion or tattooing or trauma or exposure to pets. There is no history of seizures or abdominal distension, bone or back pain or breathlessness. Past history, he has no medical comorbidities or previous surgeries, and there is no history of any similar complaints in the past. Personal history, he has a mixed diet, appetite and sleep is normal, bowel and bladder habits are unaltered, not a smoker or alcoholic. In family history, there is no history of similar complaints in family. So summarizing my history, he is a 64 years old male from Telangana presenting with complaints of a continuous dull aching right upper abdominal pain with generalized weakness, giddiness, loss of appetite, and a significant weight loss since 4 months with one episode of syncope with no history of jaundice or luminal symptoms. So keeping this in the mind, an elderly male with upper quadrant pain and loss of weight and loss of appetite, significant loss of weight and appetite with one episode of syncope. Rather, I would like to first think in terms the syncope and think in terms of cardiac or a neurological issue to rule out that, keeping in that in mind. And there is no history of jaundice and any luminal symptoms. I would like to give a differential diagnosis in terms of a malignant etiology in the organs occupying the right upper quadrant, like liver, SOL liver, or gallbladder. And if it is anemia, then I would like to think in terms of hepatic flexure growth, right-sided colon growth with anemia, or secondaries in liver. Sir.
Dr. Arun.
Yes, sir.
So, you have already described all the differentials. So,
Yes,
can you tell me, go back to your first slide, why did you ask about easy fatigability and dyspnea?
Sir, I would like to think in terms of anemia, sir.
Anemia
Yes,
because of what?
Because of generalized weakness and not able to continue his day-to-day activities.
Okay.
Yes, sir.
So, what is in your mind when you are asking about anemia?
Sir, anemia, if there is any blood loss, but rather, there are no symptoms of hematemesis or melena. So, I'm little confused about this. I'm not able to account this. Or
He
if I
has
consider,
not given any history of passing altered color blood stool or any history of
no,
that
sir.
symptom.
No, there are no symptoms.
So
So,
again, you ask for tattooing.
I would also like to consider if it is a malignant etiology, cancer cachexia can also be like this. So I'm not sure about it.
Tattooing, why tattooing? Just can you repeat, please?
Since there is no symptoms, signs of blood loss like anemia, like melena or hematemesis, I'd also like to consider since there is loss of weight, significant loss of weight, malignant etiology. So cancer cachexia can also be. I like to keep that in the back of my mind, sir.
Tattooing, I'm asking. Tattooing, you have asked for.
Yes, sir. I have asked for tattooing, sir.
Because of what?
Sir, I would like to think in terms of any liver pathology, hepatitis, to rule out hepatitis,
Okay.
hepatitis B infection, spread of hepatitis B.
So you have your first diagnosis is what? Based on all these findings. So you are thinking about tattooing means you are talking about blood borne the transferable diseases like hepatitis B and C. Is it that? Okay.
Yes, sir. Yes, sir.
Okay. So he comes from a rural background. You can also ask about there are still in the villages people are using injections which are repeatedly used in other from one patient to another patient just by cleaning in villages. So
Yes.
what is your based on all these? You said that your first diagnosis is what? You made multiple things like malignant etiology, liver malignant etiology.
Yes, sir.
So what is your first diagnosis, first working thinking?
Sir, I will think in terms of primary malignancy in liver, which is the most common is hepatocellular carcinoma, sir.
So hepatocellular carcinoma first diagnosis.
Yes, sir.
Is it that? So your this patient is started with pain abdomen.
Yes, sir.
So how common is pain in the hepatocellular carcinoma?
Pain can be there due to the stretching of the liver capsule, sir.
Oh, is that very common or it is rare or what is?
It's not so common, sir. It's not so common.
The commonest presentation of hepatocellular carcinoma is what?
Sir, mass in the abdomen, sir, and
Is mass lesion or is it other related symptoms?
sir, actually, hepatocellular carcinoma is more common in patients with cirrhotic patients, sir. So, cirrhotic patients, in cirrhotic patients, if there is any worsening of their recent worsening of their symptoms, a decompensation of cirrhosis, then we would like to think in terms of.
Decompensation would be very advanced stage. Other
Yes,
decompensation. What are the other common presenting feature of hepatocellular carcinoma?
Sir, it can be patient can present with pain. A jaundice can also be there, sir.
Jaundice would be very rare. It would be at the last stage. Jaundice should be there. Why jaundice should be there? Is it because of liver disease or something else?
Sir, no, sir. Because of obstruction can be there.
Okay. Obstruction because of what? Primary liver lesion or nodal disease?
Sir, primary liver lesion, sir.
So it will be delayed presentation.
Delayed
If there
presentation.
is nodal. So other than that, generalized symptoms like weakness, generalized weakness, as you said,
Generalized weakness.
and worsening of the symptoms and the loss of appetite, all these things, and maybe incidental finding also,
Yes, sir.
mostly on surveillance. So second diagnosis, what you say?
Sir, second diagnosis, I would like to think in terms of carcinoma, fundus of the gallbladder, sir. because in the neck it usually presents with obstructive symptoms like jaundice.
First tell about this thing. Don't go to negative point first. First tell about why are you saying carcinoma gallbladder as second?
Sir, just a malignant etiology and the organ that is present there, and also pain. Because of pain, carcinoma gallbladder will present with pain. So I am thinking in terms of carcinoma gallbladder, sir.
So why not first when carcinoma gallbladder presents with pain? Pain is the common presentation.
I don't know why. It is an aggressive malignancy, sir. So infiltration will be there.
Typical pain of gallbladder would be what?
Typical pain will be a colicky pain that is radiating to the back or infrascapular region, sir.
You want to, I'm Professor Anand here.
Yes.
You want to keep the diagnosis, provisional diagnosis one after the other, or you want to now at this stage, you want to keep both HCC as well as CA carcinoma gallbladder in the same platform and then proceed?
Sir, carcinoma gallbladder is more common in the northeastern states of India, sir. So since the patient is from
that should not come into the picture of a clinical diagnosis when you see a patient. You have to think about everything.
Okay, sir. So it can be both, sir, because both can present like this. We like to keep in the same platform, sir.
So if I may add in this history, couple of things rather than tattooing, what from the rural area. Now, since you are saying he hails from a rural area, couple of things you could have pointed out in your history is, since you wanted to say about tattooing, so you are looking at hepatitis B and hepatitis C, both can be transmitted. So dental treatment, which is more common, patients can go to take dental treatment, where sometimes in rural area they may not follow the asepsis for the instruments, injections, which Dr. TD has already spoken to you, and history of hospitalization, which you have never mentioned. Apart from that, how, if with these diagnoses which you have mentioned, Dr. Ramesh Arthanari has put up a question is, how do you explain the loss of consciousness? With either, you said malignancy in liver, which is HCC or CAGB. In both these cases, unfortunately, that episode of syncope which you have pointed out, a loss of consciousness, is also an important factor. Which, how would you like to explain that?
Sir, first I would like to think in terms of a coexisting cardiac etiology, maybe. I'm sure how
cardiac etiology. What cardiac etiology will give rise to loss of consciousness?
Sir, any arrhythmias, sudden onset of arrhythmia in old age can be.
So previous history, you have taken hypertension history. Did you take?
No, sir. Now the patient is actually he has no comorbidities, sir.
So in such a scenario, can you combine the loss of consciousness with this mass in the right hypochondria? Can you combine these two and think about some causes why this syncope could have occurred? If not cardiac cause,
Vasovagal, sure, sir.
Right. Any other organ carcinoma there in the upper quadrant can lead to anemia? Since anemia, if you're trying to explain that anemia could be the cause.
Anemia, then CS stomach or right hepatic flexure growth can also lead to anemia, sir.
By history, can you say with the confidence that it's not a carcinoma stomach? We are talking about history one.
Sir, in right upper quadrant pain, then it will be more likely a distal stomach, sir. Distal stomach usually will present with gastric outlet obstruction and symptoms. So he has no any symptoms and are not related to any food intake. Pain is not related to any food intake. So would like to keep the diagnosis down the line, sir.
So if you are thinking about liver pathology, can there be paraneoplastic syndrome which has produced this syncopal attack?
Yes, sir. Actually, in the defined paraneoplastic syndromes in HCC are hypercalcemia, hyperglycemia, and I'm not sure about syncopal attack.
The hypoglycemia. What about hypoglycemia?
Yes, sir. Hyperglycemia can cause syncopal attack.
So I think stomach partially you can rule out as you said. What about colon?
Sir, colon, there is no alteration of bowel habits, but I would like to keep that also as a diagnosis, sir. Colon.
What about pain? What type of pain do you think in the right-sided colonic cancer would have?
So dull aching pain only, sir. If
So
there
right-
is right colon are not usually obstructing lesions because of the large luminal diameter.
So that's
So
why. That's why it is that there is no progression of the dyspnea what it has been mentioned. It is only and there is no altered color. But one of the presentation of the right-sided colonic tumor is only anemia which is unexplained. There may not be
Yes,
any bowel symptoms because of the size of the colon.
yes, sir.
So with the confidence, except pain is not the usually the commonest presentation unless come to the stage the capsule.
Yes, sir.
So you did not talk about intrahepatic cholangiocarcinoma when you were talking about liver lesion and where pain could be the one of the common presentation.
Yes, sir. Intrahepatic cholangiocarcinoma can also be kept as a differential diagnosis. There.
And what about secondaries in the liver?
Sir,
Where
secondaries. I also said secondaries. I also like to consider down the lane, sir. Maybe.
but what is the commonest liver lesion? Commonest lesion in the liver.
Commonest lesion is secondary liver, sir, compared to primary, sir. But
What are the pressing features in the history which suggest that primary cannot be, secondary cannot be there?
sir, I don't have any symptoms attributing to the primary lesion, sir, like luminal symptoms. So I thought I'll keep it down the lane.
So unexplained, incidentally detected secondary is not common.
Yeah, it can be, sir. So I'd also like to keep that as a diagnosis.
Dr. Naimesh and Dr. Anand, any other point we can add or we can go to?
Oh, can you have just a presentation like this? The right upper quadrant.
Yes, sir.
Can you explain, suppose gastrointestinal stromal tumors occupying the right upper quadrant? Can you offer one differential diagnosis for this patient?
Just can also be
Same dull ache, pain, a mass in the right upper quadrant, barring melena, hematemesis, exophytic cysts arising from duodenum or from the colon, occupying the right upper quadrant.
Yes, sir. Can be, sir.
So before actually jumping to liver tumors, there are other solid organ mass which can have similar history. What Dr. Anand has already pointed out one. Dr. Ardhanar is also pointed out FEO is one of the potential differentials because you can have a right adrenal mass which can, your syncope can actually be a part of that and can be explained. Right? Pain, dull aching pain, weight loss. Correct?
Okay, sir. Yes, sir.
So I guess we can move on to examination.
Yes.
Dr. Arun, please continue.
Yes, sir. Sir, on general physical examination, the patient is conscious, cooperative, and well-oriented to time, place, and person. The BMI is 19.1, slightly on the lower side, and he is a thin built. His height is 150, a short male, and thin built and poorly nourished. ECOG score is 2. Breath holding time is 35 seconds. There is no palar, icterus, cyanosis, clubbing, or pedal edema, or supraclavicular lymphadenopathy or generalized lymphadenopathy. And there are no signs of liver cell failure. Vitals, the pulse rate is 90 per minute. BP is 140 per 80 per millimeter of mercury. Respiratory rate is 15 cycles per minute, and he is afebrile. Per-abdomen inspection, an abdomen is flat. Umbilicus is central in position and inverted. All quadrants of abdomen move correspondingly with respiration. There are no swellings, scars, sinuses, visible peristalsis, skin nodules, or engorged veins. Hernial orifices are normal. Flanks are not full. I would like to know the external genitalia examination here in the inspection. Palpation, an ill-defined firm mass is felt in right hypochondrium and right lumbar region, which is extending 5 centimeter below the right subcostal margin and is non-tender, non-mobile, has smooth surface and is moving with respiration. Fingers could not be insinuated between the mass and right subcostal margin. Rest of the abdomen is soft and non-tender. No hepatosplenomegaly, no other palpable mass in abdomen. And hernial sites, there is no palpable impulse. In percussion, liver span is 12 centimeter in the midclavicular line. I would like to reconfirm this 12 centimeter because there is a hepatomegaly, but considering a short male, I would like to reconfirm this measurement. And upper border of liver dullness is 5th intercostal space. And there is dull note over the lump, which is continuous with the liver. Flanks are tympanic. Auscultation, normal bowel sounds are heard. And digital rectal examination, normal anal tone. There is no hard nodules felt. Gloved finger stained with yellow collostomes. The other system examination, CVS, it is normal. Respiratory RS also normal. There is no focal neurological deficit. So summarizing my finding, 64 years old male with complaints of right upper abdominal pain with generalized weakness, giddiness, loss of appetite and significant loss of weight with a loss of consciousness for 5 minutes. And on examination, there was no pallor, no signs of liver cell failure, and the performance status is 2 with an ill-defined firm mass in the right hypochondrium and right lumbar region extending 5 centimeter below the right subcostal margin. So the differential diagnosis would be a primary malignant lesion in liver, which is HCC, or a carcinoma gallbladder. Secondary sign.
Again, here, if you put a FEO or a right adrenal mass, because
Yes,
there is no anemia, you are not able to explain the other causes. So a right adrenal mass, probably second would be CAGB, then it may be a malignant lesion in the liver.
Yes, sir.
Right? Because even your findings
Mm.
have similar findings in a right adrenal mass.
Okay.
Correct?
Yes, sir.
Except that Dr. Naimesh said this mass is moving with the respiration, so that may not be.
Is it moving?
Okay.
Yes.
Is it moving with respiration, sir?
Okay. Okay.
So Arun, by after examination, what
Yes,
are
sir.
the 2-3 things we thought in the beginning are excluded from the differential?
Sir?
We were thinking about so many things. We thought about yeast, we thought about stomach, we thought about colon,
Yes, sir.
then liver, then gallbladder. So can
Yes,
you
sir.
say with the confidence that these are the organs now, they are out of the discussion?
Sir, I would not like to consider CS stomach, sir, because I feel
To explain, just stomach most probably excluded. Then,
sir, also colon I will rule out, sir, because the patient is not anemic, sir. There is no pallor.
just colon excluded. Go ahead. Then. So now you are left with liver lesions and gallbladder lesion. So why
Yes,
are
sir.
you keeping SCC as the first diagnosis?
Sir, initially I thought since he is from the Telangana, but now I would like can be both, sir, because see a gallbladder fundus was infiltrating the segment 4 and 5 can also present with a similar findings, sir. And so I would like to keep both in the same platform.
It mentioned in the presentation the surface is smooth.
Smooth, yes, sir.
And there is no suggestion in the examination of any liver lesion. Sorry, any chronic liver disease.
Yes, sir.
And then what are the percent of the primary liver lesions which are present in the normal liver without preceding liver?
It is rare, sir, actually. I'm not sure about the percentage, but it is in a non-cirrhotic liver, HCC is
What percent?
5% maybe.
No, it's not 5%, not so low, but it is about 10 to 15% of the liver lesions would be HCC would be without preceding this thing, and they have special characteristics. So I think and are there some HCC which can be present in a without preceding cirrhosis?
Yes, sir. Hepatitis B in the setting of hepatitis B, it can become HCC is a possibility there without cirrhosis.
And only B are recent trend in
hepatitis C also can present, sir.
C cannot present.
Oh, yeah, C cannot present de novo, so only B.
What about NASH?
Sir, yes, NASH metabolic dysfunction associated fatty liver disease I think can present
Clearly
cirrhosis.
So if I say it is carcinoma gallbladder, what is your objection? It is lower down, it is coming down, and it can how will you exclude carcinoma gallbladder and keep you as a second diagnosis and HCC as a first? Just because of the one point you have said in the beginning that it is because the patient is coming from South India. What are other things by which you are trying to keep HCC as a first?
Sir, carcinoma gallbladder usually fundus is the most common location. But jaundice will be there if it is in the neck.
Jaundice is not jaundice can be there are multiple reasons for the jaundice. Jaundice can be there because of the liver lesion or because of the lesion itself and because of the nodal disease. So not only jaundice has no only one because of the associated common bile duct issue, but there is nothing in that in the history which is suggestive of CBD stone or anything like that. So jaundice you should not take jaundice as a by exclude carcinoma gallbladder. So if I have to say, I will say that most of the carcinoma gallbladder are associated with stone, and there is no history which suggests that there was earlier stone. And second is still this can happen. And second is very important point is that the pain which was there, it is dull aching, which has not 4 months for carcinoma gallbladder is a very significant time to progress further rather than same type of this thing is there. So that those are the points, but still carcinoma gallbladder is one disease which cannot be ruled out. But to my mind, it will be still considered as a very important differential. Dr. Naimesh, please.
Yeah, so again, same, see, without any signs of cirrhosis, to put your first DD as HCC is generally unusual. So I would also still go ahead with CA gallbladder as the primary first differential. I would still like to retain the right upper adrenal mass as one of the causes. It can be infiltrating the liver. That large mass can infiltrate liver, and two of my colleagues have already pointed out in the chat that a large retroperitoneal mass can also move with respiration. So I would suggest that HCC may be a diagnosis, but will probably come down in your differential rather than being, because you're not able to justify or support why you have labeled HCC as your first differential. It will definitely be a part of the differential, but not as your first differential. Right?
Okay, sir. Yes.
Dr. Anand?
Anand?
I concur with Dr. Mehta. I concur. That's we have to widely say, but in this case, many differential diagnosis comes into the picture.
So secondary is Dr. Arun, secondary liver, we thought that this is the commonest liver lesion in this thing. What are the features which are keeping secondary down?
But I don't find any symptoms or signs related to primary lesions, sir. So I am keeping it down, sir.
So
So
general teaching is, sorry. The general teaching is you keep secondaries in a single mass if you feel, you keep it as the last one in
Last.
such a case. Unless you
Yes, sir.
feel multiple
Multiple
complicated
lesions.
nodular lesions, don't offer secondaries as a third in this particular case. Right?
Yes, sir.
there are other features like examination of the liver. So you will not find a smooth liver, palpable, and the mass going down like this. And the liver would be, as you know, what are the classical features of palpation, non-palpation in the secondary liver. And what you are saying, primary presence of primary cannot be the main reason. Main reason is after examination, your the type of liver you are able to palpate. And one more important point is that there is no hepatomegaly, but there is no mention in the examination that what is the condition in the epigastrium. So it is only hypogastrium has been palpated. So if I am at your place, I will say that I would like to know what about epigastrium, because if there is a hypertrophy of the left lobe, then it is not palpable in the hypochondrium, right hypochondrium. Usually it is palpable in the epigastrium. So we take it that it should not be, but if you point it out, it is better. So
And one more point, Professor Ramesh Adhanari has mentioned, can this be hemangioma? He has asked a question. How do you substantiate or not agree with that diagnosis? Arun?
Yes, sir.
Can
Sir,
hemangioma be a differential diagnosis?
can be, sir. But hemangioma usually will be common in females, and with the loss of appetite and significant weight loss.
Yes, that is not a constant feature of
So
hemangioma.
Dr. Arun, everything you should not be saying can be, whatever we say, you say can be. You rather than saying can be, you can say that I did not consider because patient has a significant loss of appetite and the loss of weight, and
Exactly.
all this combined, rather than sometimes the examiner wants to check your this thing, and if everything you surrender that it can be, this also can be, then I think it's not a good habit. You have put your point nicely. So you should say that since there is a so much significant loss of weight, pain is the very important presentation, and there is a loss of appetite, and if you see the ECOG score, that is also grade 2. So these are the very important points which probably doesn't we did not consider hemangioma into the differential diagnosis or any benign lesion.
Yes,
Dr. Naimesh.
That's correct. Good. We can go ahead, I guess.
So how will you proceed now, Dr. Arun? What will you do?
Sir, I would like to do an ultrasound abdomen along with blood investigations like complete hemogram, RFT, renal function test, liver function test.
Okay. So any specific thing you should, I think, okay, go ahead.
Sir, the hemoglobin is 9.3, which is low for a male, and PCV is 30. The total count is 9,500. Platelet is.
So you can say what are the reflections coming in this HCC?
Sir, he is having an microcytic anemia, sir. PCV is 30 and there is anemia.
And
so
count is normal. What does it mean? There is a significant finding that platelet is normal, which suggests that
there is no liver cirrhosis or.
It doesn't mean cirrhosis. It says portal hypertension.
Yeah,
portal hypertension.
Not the liver cirrhosis. Yes.
Right.
Yes, sir.
Surrogate marker of liver cirrhosis or portal hypertension.
Portal hypertension, where there will be sequestration and there will be thrombocytopenia.
Yes. You asked her, okay.
Sir, urea is 47, creatinine is 0.7, the electrolytes, sodium is little low, potassium and chlorides are in the normal range. Liver function test, bilirubin is normal, OTPT is normal, ALP is normal. Albumin is 3.7, which is in the normal range. Globulin is 3.2 and INR is normal, sir. So the
again,
nutritional
what do you
status,
rule out here?
sir, nutritional status is actually good, but the weight loss and the performance status may be due to the cancer per se.
No, I would say that just based on albumin, can you say that nutrition status is good? There are
Not purely nourished, BMI is low, but the liver synthetic function is good. 3.7.
Which one of the nutritional disk assessment you are looking at? Now there are some established nutritional indices. Albumin, though, is part of some of them, but are there other markers in this patient where there is a 5 kg weight loss in just 5 kg weight loss with weakness?
Okay. Nutritional markers.
How will you assess what are the components of rehabilitation? Nowadays we are doing lots of papers are getting published about rehabilitation. How do you assess the nutrition in a patient like this?
I'm not sure, sir.
So I think you must know.
No, you just see clinical. How will you assess clinical nutrition?
Clinically, mid-arm circumference
yes.
and weight.
Yeah.
Weight of the patient, BMI.
Any skin thickness you will see
Skin
somewhere?
thickness.
Where?
Yes, sir. In the arm.
See, that
biochemical?
Posterior part of the arm.
There are two components when you are talking about. One is that muscle mass, other is muscle strength. Which one is more important?
The muscle mass is more important.
Have you tried to see about multiple things how to assess this, all these muscle mass and what about muscle strength? Looking to the muscle strength. There are so many things available nowadays.
Yes, sir. Sarcopenia, CT can be used to see the sarcopenia score.
So sarcopenia.
Psoas muscle.
Then how you see the strength?
I'm not sure,
you should go after this. You should go and read all these things because there are so many things available, and only albumin. Albumin is not a pure this thing that this patient is nourished. Already you have in your examination you said that patient is poorly nourished based on whatever finding you had. So go ahead.
So again, here the examiner is trying to check whether you know and whether you want to stick on to what you have said. So everything what you said, you are willing to accept that you are wrong, will actually go against you. What Dr. TD pointed out even before is we are just trying to check that are you sure on what your diagnosis you have made. So you just need to stand firm and support whatever you have given the previous finding or diagnosis. Correct? Everything you can't just say as possible. So now, after looking at albumin, you change that no, he's well nourished. That is why he wanted to point out there are other parameters. Only albumin is not the thing based on which you will talk about nourishment. Correct? In nutrition, there are so many other factors you look at. Correct? Go ahead.
An ultrasound, which is done in November, it shows liver is normal with surface irregularity, altered echo texture, multiple arterial enhancing with portal venous washout lesions in segment 6, 7, and 8, largest measuring 10 cross 5.5 centimeter in segment 6. There is no IHBRD, CBD and portal veins are normal, and GB is distended. There is no evidence of any thickening, and other things are normal, sir.
So you are happy with the ultrasound finding? I have never seen ultrasound. Have they used contrast? This ultrasound is contrast enhanced ultrasound because multiple arterial enhancing portal venous washout regions are, these are the ultrasound finding, and you are reading. I don't know whether ultrasound can see all these things, plain ultrasound.
Contrast enhanced ultrasound with this micro bubbles can have an arterial.
But it still cannot tell you a portal arterial enhancement and portal venous washout is typical in CT triple phase, not on even contrast enhanced ultrasound. It will tell you that the lesion has taken up contrast.
Yes, sir.
Yeah, and micro bubbles. So,
Okay,
but
sir.
it cannot tell you the specific arterial uptake and a portal venous washout. Right? Yeah.
You as a presenter, where you are seeing this ultrasound, you should also look at are these findings which are written on the ultrasound, can a ultrasound even contrast enhanced? We have seen, we don't have we have started this facility, but you can see only enhancement. Not that you will see arterial phase, venous phase, but this is a transabdominal ultrasound. There is no mention that it is a contrast enhanced ultrasound. So in a transabdominal ultrasound, if these findings are there as a presenting resident, your mind should be alert, and you should say that all these findings are mentioned, but I don't know whether it is ultrasound finding or not. I am finding it difficult to accept. Then people will know that you are vigilant and you are alert. Otherwise, if you read only, then it seems that these findings can be seen on transabdominal ultrasound. That's why I said I am not aware that these things can be seen on ultrasound. If something new technology has come up, I don't know.
So what else do you want now? You have a lesion on ultrasound. It is showing an SOL in liver.
Yes, sir. So I would like to know the viral markers of the patient's HbS-Ag, HCV status.
The important thing is that surface is irregular. There is
cirrhosis and altered echo texture. Cirrhosis, I would also like to do an upper GI endoscopy to rule out varices.
So that's why he said, go on reading. What are the important things you should point out? Then only you understand that you are ready to know, and then you also see that there is a gallbladder distended, no evidence of calculus, and there is no wall thickening. So one of the very important differential is just now ruled out.
Yes, sir, ruled out.
So that is upper GI endoscopy now for you.
So esophagus is normal. There are no varices. Stomach is nodular lesion, central umbilication in the antrum. Duodenal cap is normal. B2 is normal.
So how will you take it? What does it has given you any information, or it is of no use?
Yes, sir.
So what information you have gained from this upper GI endoscopy?
Where will you get a nodular lesion with central umbilication in the upper GI endoscopy? Any classic lesions?
Sir, neuroendocrine tumors. I'm not sure.
So what do you want to do more?
So at least one information Dr. Naimesh has got that this patient doesn't have a portal hypertension.
Correct.
Yes, sir. There is no portal hypertension. There is no varices.
So Arun, these are very important findings. That's why we are trying to point out. If you plan tomorrow something by seeing the CT scan or whatsoever you tell, then at least you are aware that there is no significant portal hypertension because worries. So if you don't point it out, we should not be pointing. You should be coming out with all this.
Okay, sir.
Next. See, now this one finding in the endoscopy will alter, will bring in so many things into your diagnosis. This nodular lesion with some central umbilication in the antrum among your differential diagnosis, if you want to connect this upper GI finding, what are all the things now will be in the first differential diagnosis? Can this be any lesion invading the stomach from outside, or from lesion starting from the stomach going outside as an exophatic fashion?
There can be a lesion invading the stomach, sir, since there is also a mass in the
Which
liver.
lesions can invade? Which lesions can invade the stomach from outside?
HCC can cause an extraneous compression over the stomach.
No, the question is which. Now you have a finding right in front of you. That is a nodular lesion, it's central umbilication in the antrum. If you want to connect the lesion in the ultrasound and this finding in the UGI-scopy, what occurs in your mind? You said HCC produces extraneous impression. Then what lesion can invade into the stomach, or what lesion can start from the stomach and grow outside?
Gist
TB
can be
malignancy. Yes, gist is one of the diagnoses. Can
Yes, sir.
gallbladder CA into the duodenum or in the antrum of the stomach? CAGB?
CAGB can also infiltrate.
Okay, proceed.
So you, with this finding, when you are saying that the stomach has a nodular lesion with a central and umbilication.
I would like to do a biopsy also.
So more detailed, this thing you want, or you want to go?
Acute and chronic gastritis with mucosal erosion.
One more point, whenever you say something around luge points decrease your marks. Like you said that hepatocellular carcinoma, you have seen on the clinical examination that this particular lesion is going from the right hypochondrium to the right lumbar region. So by
Yes,
no
sir.
of imagination, until unless it is a left-sided lesion, it can compress the liver. Stomach gallbladder cancer, usually duodenal compression is there. Usually stomach compression is a rare phenomenon. So if you see a lesion like this, in a lesion which you have already palpated and upper GI finding is this, you should go a little bit beyond that. I would like to have more information about the lesion. One single small lesion with umbilication, nothing else has been described. So before saying that, we should try to have more detailed upper GI endoscopy, and you have rightly said that biopsy has come and which has shown that it is gastritis, but we don't know still, because we have not seen the lesion. Only we have seen is umbilication. We don't know what was the size of the lesion. Was there some submucosal protrusion and any other area? So very subtle information we have got there. What is the next investigation we would like to do?
I would also like to do a chest X-ray to rule out any obvious lung metastasis, and then I will go to a multiphasic CECT abdomen and pelvis.
But in the blood
With chest.
investigation, you did not ask for anything.
Sir, I also like to do a tumor markers, sir. Tumor markers, alpha fetoprotein.
Say in the beginning that what tumor markers you wanted to know.
Alpha fetoprotein, sir.
Okay.
Alpha fetoprotein is 353 nanogram per milliliter, which is increased, sir.
Increase means what?
What is normal?
So normal is up to 15, sir. If it is more than 400, it is more likely to be HCC. If it is more than 1000, then it has a prognostication value also.
No, it's 1000 is too much value we are talking about, but it is significantly increased. Significantly increased, yes, sir. And what other investigations you have left behind? There are so many things once you are seeing
Yes,
the type of liver and ultrasound. So blood investigation you are leaving behind. Other investigation in this patient, you talked about tattooing and all those things also. In a liver like this and your a history like this, you only asked about tattooing and blood transfusion. We talked more about injections and dental extraction.
Sir, I asked for viral markers and
did not ask. That's why I'm asking. There were no
Yes,
no other markers had been seen. Okay.
Yes.
You see this?
HBS AG is positive,
Yeah.
and HBE is positive. HBE antigen is negative. Antigen is negative and antibody is positive. HPV DNA viral load is high,
Mhm.
and HIV is negative and HCV is negative.
So
Sir, so it is hepatitis B positive patient.
4 is positive. 4 is also positive. Surface is also positive.
Yes.
So what we started in the beginning, that patient can go to the HCC even without going to classical cirrhosis
Yes, sir.
in hepatitis B. Can you tell why this thing happens in hepatitis B?
Sir?
Why the hepatitis B patient don't follow the sequence of hepatitis going to nodular?
Sir, HPV DNA will integrate with the host DNA and can develop into HCC.
So now
We
what is
know
the investigation?
What about HCV? Will HCV, how does HCV cause?
HIV and HIV is negative, sir.
No, if suppose what happens, the pathogenesis in HCV, hepatitis B, hepatitis C, and
Hepatitis
HCV.
C will cause cirrhosis, and from there it will HCC can develop from cirrhosis.
So HBV need not have a cirrhotic picture.
Cirrhotic picture for.
No, it can cause HCC. That is because of the viral DNA can integrate into the DNA of the hepatocytes and
Hepatocytes,
produce.
yes.
Yes. But what is this picture? Having going through the viral markers pictures, what is the status of hepatitis in the patient?
Sir, the viral load is high, and
Yeah.
since HBE antigen is negative, there is no. I would like to. The infectivity will be low, sir.
Infectivity is shown by HBsAg. What does HB, what Dr. Anand is trying to point out is HBE antigen and HBE antibody. What does that signify?
It is an active infection.
So is there an active infection? It means what do you mean by active
No,
infection?
if there is an active infection, then it should be hepatitis. There is no elevation of OTPT.
So the word is not active infection, it is
Active.
replicating.
Replicating, yes.
All right. So
Yes,
hepatitis
sir.
surface antigen is positive means he is infective. He can pass on the infection to the others.
Yes, sir.
Correct?
Yes, sir.
If the E antigen is negative and he's developed antibody, means that is E is what? What does E stand for? HB core is not given unfortunately, but what does hepatitis E antigen? E is what? What is E in that HBE?
S is for surface, C score. E is
E antigen, yes.
That is indicative of replication.
replication.
Yeah, but what is that
E?
E?
What is that?
What is that E? C is core, S is surface.
C
What
is
is
surface. E.
yes? What is E? E is envelope.
Go and read the
right?
viral structure.
You need to read.
Go read the viral
Envelope.
structure.
Okay.
Microbiome.
Mm.
Envelope. It's an envelope.
Envelope, yes.
Indicative of replication. Why do you want to know about this point? Why do you want to know about this in a patient with HCC? What do you want to know about this?
Sir, HCC, we, simultaneously have to treat antiviral. We should give antivirals so that will have a better prognosis in the.
Is it prognosis?
No, the hepatitis can worsen the disease still. Sir.
So it is a field change actually. So it actually prevents recurrence in the same place after you treat the patient, and also multiple lesions from occurring from other segments of the liver. So
Yes.
you should know this point whether to start antiviral therapy along with your primary treatment. Yeah. Please go ahead.
I like to do a multiphasic CCT abdomen and pelvis for the patient.
Okay. Do we have that?
This is the plain CT of chest and abdomen. I don't see any cross lung metastasis here.
I don't think you should point it out because there was no lung
This
window.
lung
You should
window
not have, you should
better.
not have commented.
Okay.
There was no lung window. This is abdominal window.
Yes, sir.
Can you see something coming up?
Yes, sir. Plain CT.
What?
This any taste particles can be like some hyperdense material in the lesion, sir. I don't know whether it is taken before.
There is no history in your history. You did not tell that he has been treated partially.
Can we see the first CT? I think this is 10th March CT, if I'm not wrong. Do we have the first CT, the CT before? The CT is 10th March.
This is the
2024.
initial CT without any treatment, sir.
Okay, because the date here it shows 10th March 2024.
So that is proxy, sir.
Acha, okay, sorry. So there is no treatment given, Dr. Arun.
Yes, sir.
Neither in history and here also we have got it. So what that could be? You are saying there is some hyperdense material. It is very important for you to see. What else? What is the other phase you want to see? And why the plane was important?
Sir, plain is to rule out any calcifications and other fluid, free fluid can rule out, or hyperdense can also.
So did you say, first of all, there is a mass? Where is the mass?
Yes,
describe the location, the extent. Then you say what is there in it. Correct? He's showing you again.
Sir, mass arises from the segment 5 and it is 5, 6. It's actually from 6 and it is extending downwards. It is an exophytic lesion. Extending into the lumbar region, sir.
Okay.
I'd like to go see in an arterial phase.
Why are you not commenting about that region? What could be there? It could be, why are you seeing the
Sir, bleeding can also be there inside.
Can you compare with the bone?
Yes, sir.
So what should it be? What do you think it is there? You see the vertebrae and you see that where you are putting your pointer.
So it could be calcification. I would like to think in terms of.
Necessarily, you have to say that it could be a calcification in the mass. You are seeing the liver border, liver margin, and it is clearly in the mass. Though you cannot say how much, what is the size of mass and all, but it is inside the mass. So it is a calcification. No treatment has been given. You have already.
Yes, sir. It is a calcification in the lesion.
But why did you comment about taste in the first instance? Taste particles after seeing this CT?
Sir, it is a large mass, so I thought.
No, we have not gone
since
through the
that
contrast.
was 11.
No, we have not
taken,
gone through the. Arun,
yes,
we have not gone through the contrast film, triple phase liver CT. Only plain has been shown to you. Suddenly,
yes.
Why did you say it is taste particles?
Taste particles also will look like this. So
what is used in taste? That is what he's asking you.
Why used in taste we use lipoidal solutions, sir. It's an iodized oil that will be like this.
So it's not mandatory. No, you don't know what treatment has been given. So I think it's not good to use case one. There is nothing in the history. And nowadays,
Yes,
in the changing scenario, in this type of things, you cannot be sure that this is the case only. So I think don't put unnecessary words so that you are stuck up there.
When you say I see some, I am thinking in terms of calcification in a plain CT, acceptable. But we have not demarcated the lesion where it is starting from. We don't have a triple phase CT, liver CT with arterial and venous phase picture is not there. Commenting straight away that I see taste particles generally is not acceptable.
yes,
Plus also this film which is showing, it is hyperdense. Remember this, we'll talk to you about this later again. There is hyperdense in that. So why is that important? We'll discuss in the next once you ask for the other scans.
yes. Sir, I would like to see the arterial phase.
Go ahead, because it is already 9 o'clock. So we would like to finish.
That is arterial.
Yes, sir. This is an arterial phase. I like to see the arterial anatomy and the lesions.
I saw something else also. You are not seeing it.
Yes.
Eyes are not good, or you are ignoring it. Other than lesion, which is very significant to me.
There is also dilated CBD. Sir.
I don't know where are you seeing.
And there is non-rim arterial enhancement and deletion.
What happens to the hyperdensities? He's just showing you that lesion again. You now you go back and you remember the plane scan. How was it and now what it is?
Sir, it is enhancing. Sir.
So has it increased, decreased?
Increased, sir.
So what does that signify?
Sir, it is a arterial hemorrhage inside.
Where?
Inside the lesion.
Right. And something else which he was showing you and what Dr. T.D. Yadav was also asking. Where? Was anything else you missed out when he was showing you the scan, uppercuts?
The uppercuts. You go to the uppercuts, you are seeing the
Yeah.
liver.
Surrounding the liver. Surrounding the liver, what do you see?
Sir, there is fluid there.
Very significant finding. You cannot miss it. You cannot afford to miss this finding because all the other treatment will be decided based on all the findings you are seeing here. Everything is important.
It starts right from the dome of the diaphragm.
Yeah. Yes, sir. So it could be a.
See, it starts here. He's showing you there is all fluid collection which is going down.
Yes, sir.
So will you call this as ascites?
No, sir.
Why? Why not?
Just in the.
Why not? He's trying to help you with the answer. You should just pick up what he's trying to help you with. Why not? Why not ascites?
Sir, it is mildly enhancing there. So I'd like to think in terms of ruptured HCC or hemorrhage.
Very difficult to show it is ruptured, but there is definitely fluid which is not enhancing. See, the liver margins are clearly defined. So, and the thing is that there is no fluid around the spleen. So that those are the regions, and then go down.
Yes. So he was trying to go down to the pelvis to tell you.
Yes, sir.
In this area, you are not seeing fluid.
In pelvis, there is no collection in the pelvis.
Yes, correct. So, but you should have told that as an answer. He tried to help you show the pelvis, right? There is some fluid he's showing you now.
Yes, sir.
Can you see that fluid? He just showed you some amount of fluid in the pelvis.
Some amount of fluid is also there in the pelvis here.
Yes, but very small amount.
Yes, sir.
Now, what else you want to see? Anything else you want to see? This is the arterial phase.
Yes, sir. I like to see the portal phase.
So this should have come from you. You don't wait for the examiners to ask you.
Yes.
You remember we discussed arterial enhancement and portovenous
And
washout.
portal venous
It's not
washout.
correct in the ultrasound
When
report.
you are showing arterial picture, it's also important to show that this is the right hepatic artery, this is the left hepatic artery, this is the common hepatic artery. This is also important to tell the anatomy. Then you go.
Yes.
Please go ahead, total vein, because as I already said, it is 9:05. So we should finish on time. Already we have.
Sir, I can see the classical washout in the portal venous phase, and there are no any tumor thrombus in the portal vein.
So you should show that I am seeing the right portal vein which is looking normal, left portal vein which is looking normal. All these things.
Normal. Yes, sir.
Is looking to be involved. There is no other lesion. So these are the things you should come out.
Yes.
Not in pieces. Whole CT scan has to be described in the exam. What about liver? Liver, it was in the ultrasound, it was told that liver is irregular. So surface analysis is
Sir,
important. Size is
but
important.
here the surface seems to be normal, sir.
Okay.
You don't see any irregularities here in the liver surface.
So
Any
don't
certain-
use the word. Say it is the surface seems to be smooth,
Smooth.
no lobulations,
No
no
lobulations,
nodularity
yes.
seen, no nodule seen. Okay?
Yes, sir. Yes, sir.
Use proper terminologies when you are answering in an exam.
Yes.
So what do you want to
Oh.
do?
Sir, it is large lesion in the segment 6, 7.
Where is,
So,
where is segment 7? Show the lesion in segment 7. Show the right hepatic vein. Then only
Where is segment 7? First describe
sir,
where is
actually,
7.
no, sir. It's in segment 5 and 6 extending downwards, sir. The extophatic lesion into the, it's not in the segment 7.
So all these hints should not come from the. You see the right hepatic vein? Are you seeing the right hepatic vein?
Yes, sir. Sure, I see the right hepatic vein.
That should be segment 7. Show the segment 7.
So where is 7? You
7
tell
is
me.
upwards, sir.
What do you mean upwards?
Sir, above the portal vein bifurcation is segment 7.
And
And to the right of the right hepatic vein.
so lateral is the right word to be used rather than saying right or left. So the lateral to
Yes,
the
sir.
RHP, correct?
Yes, sir. So, considering the patient's performance status is
No,
an
no.
ECU.
Just tell us what about the lesion. Which segments are involved?
Okay.
Okay, so you have gone to treatment now. So tell the treatment. What more you want to do before you are ready for the final management?
Sir, I want to see the reports, and since the patient's status is ECOG2, and I will not
Yes.
I'll think about the surgery in this patient later, sir. But first, initially to rehab, stabilize the patient, and since his performance status is 2, he comes in the advanced stage of
What will you do to the
HCC.
ascites? Free fluid is there. Liver to you are looking normal, not with the thing. So what about ascites?
That is very mild perihepatic fluid noted.
Yes.
Hyperdense ascites noted. Hyperdense ascites means maybe could be due to hemorrhage, sir.
So Anything we have to do, or we don't want to do anything? That is what I am saying. What is our final plan in this patient?
I want to, since it is a ruptured HCC, I will go for an initially palliative sort of treatment. I'll go for a TACE, maybe.
Any preparation?
And
You don't want to confirm whether it is really this thing. Have you seen coagulopathy? Did you see? I'm forgetting whether
INR is normal in this patient, sir.
What about hepatitis B, which is a surface antigen positive, and you saw the viral marker load of the virus? So we have to manage patient in totality, not that you just see the tumor. So what are the things which are required to see?
Sorry, sir. Sir, actually, we'll see if the liver functions. We'll then the performance status of the patient, and then we'll discuss in a multidisciplinary team, and we'll plan the management for this patient.
Dr. Arun, everything is with you now. Everything is with you. You have the ECOG status with you. You said to LFT is
Yes,
there
sir.
with you. Patient is right in front of you. We have all the everything.
Sir, I would like to do taste for this patient because since the portal vein is also normal and there is a good portal flow, I like to do a large lesion. So I'd like to do a taste for this patient, sir.
I disagree
Taste-
with explanation or justification. What do you mean by portal flow is normal? How did you judge the portal flow based on CT scan?
Sir, portal, I'll see if there is any thrombus in the portal vein.
So you can't say the flow is normal. Again, you are using so many loose terms.
Yes.
And if the portal vein was thrombosed, you won't do TACE or you can't do TACE.
Sir, if there is
Is that a
portal vein,
justification for TACE? Is that a justification for TACE? That portal vein does not have thrombus, so I'll do a TACE.
no, sir. It is since it is a large lesion and it is a patient is ECOG status is 2. I want to do a taste for this patient, sir.
So do you do TACE for large lesions? What happens if you do TACE for large lesions? What are the complications of TACE? Are you aware of that?
Yes, sir. Taste can if taste can result in liver decompensation, liver failure. If there is a large lesion and a compromised liver function, it can result in liver failure, sir.
But Arun, everybody is trying to hint you. Do you want to prepare this patient more rather than taking a decision right now that TACE is recommended? You have seen the liver. Liver has not shown any other feature of chronic liver disease, so significant chronic liver disease. If at all
Yes,
it is,
sir.
might be child A, early child A. So we have
The
to.
patient is not having cirrhosis, so okay.
So how will you prepare? That is the important point. Would you like to start antiviral? Try to see
Yes.
what is that is the ascites. Is it ruptured this thing, or is it because of the nutrition is 3.7 is the albumin? So it seems that it is probably most probably there will maybe leak from the tumor. So
Yes, sir.
hemoglobin was, you saw it was 9. So if
9.
you see the ascites the way it is, you see the progressive this thing. If you correct, first you prepare the patient. 9 hemoglobin patient, you will take a decision.
No, sir. I'll first transfuse blood. I'll
To be prepared very thoroughly, and then only you take a decision.
yes, sir.
There are
See,
Will you transfuse blood at hemoglobin of 9? Only because the hemoglobin is 9. So many patients come to your OPD with hemoglobin of 9. Do you admit all of these and say, I'm transfusing blood? Come on, get admitted. Is that what you do, Arun?
No, sir. No, sir.
So then why did you say blood transfusion? Because hemoglobin is 9.
So
what the examiners are trying to tell you is whatever you answer, you need to justify your statement.
yes,
What is
sir.
required when you give blood transfusion? Even if hemoglobin is 9, sometimes even with hemoglobin 10, you may need to give blood. But when do
Sir,
you do?
since I'm going to go for an intervention for this patient, I wanted to do a transfusion, and I'll prepare him for the intervention, sir.
So if the patient is actively bleeding, is hemodynamically unstable, is what I was looking for. That is the time you will need to give blood transfusion.
Okay.
Correct?
Yes, sir.
So hemodynamically, so this is what you should have answered. If the patient is hemodynamically stable, I may not need to give blood transfusion. I will give antiviral treatment, give hematinics.
Yeah.
Yes.
Correct?
Yes, sir. And then I will proceed for the treatment, sir. Yes.
So
What is
when
your intention, Arun?
Sir?
Here is a lesion where the liver is, rest of the liver is normal. And the lesion in segment 6, 7 and peripherally exophytic lesion, accepted it is a large lesion. Patient
Yes,
except for ECOG2, other parameters are very good for a resection. What is your intention of this?
Sir, I would like to downstage the tumor.
Point, you said it is already a ruptured tumor, which is settled now, which is again prone for rupture later.
Yes, sir.
Why don't you resect? And what is your, if at all, what is your intention for this?
Sir, I don't go for resection in this patient upfront surgery because of the poor performance status. I would like to do TACE, and it can downstage the tumor, sir. TACE can downstage the tumor, and after that, I will reassess the patient, and then I will look for the further options, sir.
TACE, so
also,
your intention of TACE is only to downstage?
No, right, sir. To downstage and also to prevent the progression of the tumor, and as a bridging treatment, I do TACE.
So does the tumor perforate? You use the word perforation. Am I right? Did I hear it correctly?
Yes, I don't see any perforation, but there is.
You use the word perforation, correct? To avoid perforation is yes, what your second point you answered.
Now I will ask you, why did he develop a syncope in such a huge tumor? When will syncope attack in HCC? What is the reason? One is
because of
one is rupture, yes, and exsanguination. Rupture and exsanguination is one scenario. Now
yes,
patient recovered. After that he recovered. So where it can happen in HCC? Sudden syncopal attack, hypotension, patient again recovered later. Where it can occur? Now you have seen the CT picture, everything. Can you explain the syncope now? Why it would have occurred?
Because of the exsanguination, maybe.
What happens when the tumor keeps on growing? Do they develop central necrosis of the tumor?
Yes, sir.
What happens when necrosis happens?
When there is yeah.
Okay, again go and read. You have to read a lot about the pathology of HCC.
Okay,
the
sir.
Natural history and pathogenesis of HCC. So now, what is TACE and how will you give TACE?
Sir, TACE is transarterial chemoembolization, and we give chemotherapeutic drugs mixed with the lipoidal solution, and will inject in the arteries. It's subsegmental arteries. Will point towards the feeding arteries of the tumor, and they will inject it. And they also inject embolizing particles like PVA and gelatin sponge, so that the embolization will cause a necrosis of the tumor, and the chemotherapeutic drugs will act and will bring down the tumors. And the most commonly used chemotherapeutic agent is doxorubicin. It can be used. Sir. Yes, there are also recent things like DEB test, drug-eluting beads. Test can also be used.
How will you follow up the patient after TACE?
Sir, after TACE, I would like to review the patient in for 4 weeks, and we'll see the
Immediate
with the CT.
complications. Immediate complications. Suppose you have done yesterday evening. What will
Yes, sir.
you do today in the ward? What will you do today in the ward?
Sir, I would like to see if there is any the hemodynamic status of the patient even after doing TACE, because there can be any arterial injury can be there, or
Where? Arterial injury where?
the hepatic arteries or the TACE can result in also the embolization.
Next day morning you go for rounds and patient says, I'm not able to move my right limb, lower limb.
Yes, sir. Because of the femoral the artery that we have chosen, there can also be ischemic injury to the artery, sir. Femoral artery.
What will you feel after immediately you enter the ward the morning, next day morning?
Sir, I'll look for the pulses.
Where?
The femoral pulse, distal dorsalis pedis, sir.
See, you have to come out with everything by yourself. Right?
Yes.
So many leading questions. It's a simple procedure. You see, go on morning, assess the femoral puncture site, see for a hematoma, see there is any nerve injury, femoral nerve injury, dorsalis pedis, and you arterial pulsation. Sometimes these beads might disrupt and it can cause cholecystitis, no? Severe cholecystitis.
Yeah, cholecystitis can occur, or the arteries.
Patient may have severe right upper quadrant pain, tachycardia, fever, and these things you should assess. Right? It should come from your side, tuck, like that. Yeah.
Yes.
What is post-TACE syndrome? You don't know. Yeah. So you need to read.
It can result in the gastroduodenal arteries or hepatic gastric arteries can also be got embolized, or that can result in gastritis, ischemic gastritis can occur. Be related to that. I'm not sure, sir.
That is not post-TACE syndrome. You need to read what is post-TACE syndrome. All right.
Yes, sir.
And the intention of TACE is not to downstage the tumor. When you downstage a tumor, when your intention is to cure him. First, the word I want to palliate. So you are doing TACE for what? Is it for downstaging? No. What is your first primary intention for TACE?
Sir, it is a palliative treatment. So since he is
what is your primary intention to do TACE?
Sir, to prevent the progression of the tumor and to bring down to control the disease. Primarily to
Arun sir, he has a ruptured or he has bled inside the tumor. Tumor will bleed. You want to stop that. He has had a syncopal attack. His hemoglobin has dropped down. Everything is evident, which was there, which you only have pointed out.
Yes, sir. So in this patient, yes.
Okay. Dr. Anand, sorry, please continue.
Yeah, suppose how long you will take to do the next scan for this patient after TACE, and what will you see when you follow?
Sir, after 4 weeks, I would like to do a scan, and I will assess the size and the viable tumor that is present inside the.
What criteria? With what criteria you will follow this size?
Sir, in LIRADS also they have defined it as LR, the viability after treatment response. They used to say LRTR, and RECIST criteria can also be modified RECIST criteria can also be used.
Suppose you find, because time is very short, suppose you find the tumor says the same size, or in fact it has grown 1 centimeter larger than the previous case. What is your inference?
Sir, it is a progressive disease, sir. So if there is in modified RECIST criteria, they say that it is if there's reduction more than 30%, then it is a partial response. If there is an increase in more than 20% of the diameter, smallest diameter measured before treatment, then it is a progressive disease. if if that doesn't fit in between these two, then we term it as a stable disease.
But you have nicely embolized. You are sure that you have nicely embolized the hepatic artery, supplying the tumors. But still the tumor is growing. What else your mind thinks? What else it could be? I accept your point. But what
Yes.
other things can cause this?
So maybe there will be intrahepatic, there will be communication between the arterial and portal vein. So still we have not embolized it fully. I'm not sure.
Then HCC is large HCC supplied only by the hepatic artery of that particular.
No, sir. Portal vein it also takes blood supply from the portal vein also, sir.
Any surrounding structure vessels can supply the HCCs from diaphragm,
HCC.
perigastric
Yes,
vessels,
sir.
pericolonic
Perigastric
vessels.
vessels, colonic
Pericolonic
vessels.
So
Yes.
what will you do in such scenario?
So we have to embolize all the feeding vessels, sir.
Lot of accessory vessels.
Accessory
Lot of
vessels. Yes, sir.
accessory surrounding organ blood vessels. The tumor takes its blood supply from that. So you have to target those vessels also during the primary phase. So that
Yes,
we
sir.
need to have a very good intervention radiologist to look into all these factors. But
Yes, sir.
and you should also be very careful when you take supply from right colonic blood vessels. You can't go and embolize all those things because it will produce severe infarction of the colonic vessels and other perigastric vessels. So you should be very careful about that also.
Yes, sir.
So retase 4 to 6 weeks down the line to reduce the size further and avoid further bleeding.
Yes. Okay, sir.
Retase, yeah. So now he has come read. Go ahead. Follow up.
He came for follow-up. There is a generalized weakness. Patient developed melena with hematochezia, drop in hemoglobin from 11 to 8 despite of 2 units of PRBC transfusion. So there will be melena means there is luminal bleed inside and hematochezia also.
So now what? Now what do you want to do? Is there in your OPD? What do you want to do?
Sir, I will admit him again.
Good.
And yes, sir. And I will evaluate him. He'll check his hemodynamic status. I will resuscitate him since there is fall in hemoglobin. And I will see since there is melena, I'd also like to see an UGScopy now because since post-stage syndrome, he can develop these things.
This is repeat endoscopy.
Yes, sir. A prominent vein at lower end of esophagus. In stomach, there is portal hypertension gastropathy.
So what else do you want now? Any other investigation you want? There is something else also which was written on duodenum, on upper GScopy.
Duodenum cap is deformed at superficial ulcer. It also developed ulcers in the duodenum.
Due to?
So it can also gastroduodenal arteries and be embolized because of that ulcers.
Inadvertent embolization of the other vessels.
Embolization of other vessels.
Inadvertent
Embolization of the other vessels.
What else? Any other investigation you want to do now again? He has bled. He has come back to you. You have done
Then
taste.
I would like to do again repeat imaging of the patient.
Correct. So come out with it. Very good. What imaging do you want?
What imaging?
Sir, I will like to do an again arterial enhanced multiphasic CT, sir.
So there he is showing you again.
Is a plain CT?
Yeah. See how did you see how a taste lipidal will give appearance?
Yes, sir.
And what you were saying before, which was taste, which was probably calcification or a bleed. Can you see the difference between how the appearance is there?
Yes, sir.
Now, what has happened to the lesion?
The lesion has grown still. And has gone for some necrosis.
Yes.
The lesion has significantly increased in size, sir.
And still there is hyperdense material in it. Can you see that?
Yes, sir. Yes, sir.
Yeah.
So there is still hemorrhage in the
Still ongoing hemorrhage.
ongoing hemorrhage.
Yes.
What are those air pockets you see there inside the lesion?
Sir, necrosis because of maybe followed by that infection.
And the gas will be the infection.
You want to go to the arterial phase now?
Yes, sir. You see the arterial phase now. There is
What
still there is still a hyper enhancement in this. There is still bleeding into the tumor.
Yes.
The embolization was not adequate, sir.
Yes. And what type of appearance also it is showing you, the tumor. This will give you an idea as well. What type of appearance it is showing.
Peripherally, if you look, there are a lot of
Peripherally is
arterial enhancements. Peripherally.
peripheral enhancement is there, but
Yeah.
I'm not sure
Many
why.
arterioles are seen in and around the lesion again.
Here I see artery. Size is increased and they have developed collaterals also.
Where? Collaterals where?
Sir, here.
So that is all neovascularization. There's a lot of stranding around.
Yes, sir.
Yeah. So that is called as stranding and neovascularization. Correct?
Yes, sir.
So this gives you an appearance which is more in favor. Shows the portal venous phase as well. This is a classical appearance of what type of HCC. You could see in the portal when he started, there was fluid in the pelvis as well.
Yes, sir.
Yeah. Lot of stranding around the tumor. This is what you should be describing, Arun. We are telling, we
Yes,
are
sir.
examining.
Yes, sir. Sorry. There are a lot, sir, I'm just looking at a lot of stranding, sir. And the portal vein appears normal. I don't know what is it a particular type of HCC. I'm not sure. So I'm seeing a lot of collateral, still neovascularization here around the capsule. There is enhancement in the around the capsule of the tumor.
So it's a peripheral enhancement.
Yes, sir. And still there is fluid inside the pelvis.
Is it more less compared to the previous scans?
Sir, it has increased, sir. A lot. Fluid is increased. patient is also going for assay test.
Yes. So now what do you want to do?
I like to conservatively manage this patient. Sir.
Come back again.
I like to manage best supportive care for this patient.
What do you mean by supportive care?
Sir, I will treat as what is the symptoms? I'll try to treat his symptoms, sir.
He's bleeding.
I'll like to do blood transfusion and I'll see to whether interventional radiology can help again with any embolization.
They've done 2 tests. The IR guy says now I can't find anything more. If I do anything more, I might embolize the feeding vessels to stomach or colon, which can lead to ischemia to either colon or stomach or
Yes, sir.
duodenum.
Now you see there's a lateral mass, you said air pockets, no? So the
Yes, sir.
mass is communicating with the ascending colon, involving the medial wall of distal ascending colon just below the hepatic friction with the air pockets within the mass communicating with the ascending
Yes.
colon. It is communicating with the ascending colon. Now patient has got melena and hematochezia.
Yes, sir. So I like to do some form of
Do you think
diversion.
bleeding will stop with what form of phase or any embolization will stop this
No, sir.
bleeding?
It will not stop. But, offering a surgery for him to I'm not sure.
So at 65, there is a gentleman who has bled twice. You have offered taste twice. The mass has increased in size in spite of taste being done. Has represented to you. You have given him a chance, seeing that the size decreases or not, which has not happened. The tumor has now invaded into the ascending colon.
Oh,
What do you want? Just admit him, give him IV fluids. If he bleeds, you give him blood transfusion and say, sorry, I can't do anything more. Yes, no, I disagree.
yes,
I
sir.
would agree.
I cannot. I think cannot offer much to him, sir. So,
I think as a surgeon, I would want to offer
If at all
bleeding.
there is a chance to save the patient, what will you do? If given a chance to save the patient's life, and you
we'll
don't
go
have
for
any
an
other option,
hepatic artery ligation, and still he has got many
that's all ruled
collaterals
out. Now there is
ruled out.
that's all
Yes, sir.
ruled out. The tumor is even in spite of your best treatment, your radiological means. Patient is now the tumor is growing. It is taking blood supply from other organs, and it has invaded the ascending colon. Patient is melena hematochezia. What can you take some risk at all and do something for the patient?
Can
Explaining
do
the high quality of the surgery.
yes, sir. I can go for an resection. With this
What type?
en block section.
Block. What do you mean? You remove the whole liver and what else?
No, sir.
Then
The no, I will some sort of
Anatomical, non-anatomical, palliative
non-anatomical resection, sir. Maybe palliative resection with we involved colon also, sir.
so that is what there is no arm block here. You are not doing a radical surgery What you
Yes,
are
sir.
doing is basically to reduce his bleed. It is a palliative surgery being done. You said you will ligate hepatic artery, which I disagree. So then you again change it. I'll do non-anatomical. All these answers could have come from you. Since it is an exophytic growth coming from segment 6,
6.
I would prefer doing a non-anatomical resection to save the parenchyma of the liver. And if required, which is likelihood since it has invaded into the ascending colon, I would like to resect the ascending colon as well. So what will be that resection? It will be a right hemicolectomy
Yes, sir.
with or without
Right
stoma. You need to
right
complete your
hemicolectomy with
HCC.
right hemicolectomy with stoma in this patient.
So what type of stoma?
Sir, I'll do an ileostomy, sir, in this patient.
What happens to
So
the distal stump?
distal loop I'll close and I'll put it inside, sir. Patient.
Dr. Anand wants to comment.
No, it's okay, whether you anastomose or not, but you have to do some palliative surgery right at this junction. You don't have any other alternative. Please give a chance to him so that you can save the patient from bleeding. That is a wise decision to be done as a surgeon.
So certain points I would like to say is when you say about resection, Dr. Anand actually did advise you to do non-anatomical, otherwise you were not sure. So you should have asked for a, if you want to go for a larger surgery, you need to check for volumetry.
Volumetry scan. Yes, sir.
But sir, you never said that. That is what I'm trying to tell you, that you should be coming out with these points. You should have said, I would like to do a CT volumetry, find out the size. Now you said volumetry. What volumetry are you looking at?
Sir, I'll look for
You want?
the sir, future liver remnant here, since it is in the segment 6. I'll see the total liver volume and the tumor that is going to remain, sir.
So again, your words, what you describe has to be really precise and specific. I look at the total liver volume. I look
Total
at the
volume.
tumor volume. I will look at the part which I
Okay.
need to resect, and what I'll also look at the volume of which I want to preserve.
Yes, sir.
I will subtract the tumor volume from the total liver
From the
volume
tumor
and then calculate the future liver remnant based after deducting the tumor volume. This should have come from you.
Yes.
Okay.
Yes, sir.
Good.
So that will be a standardized future liver remnant. So
Yes. Okay.
yes, sir.
And as a GI surgeon, you need to complete your answer. You are justified in saying, I want to do a resection and a stoma, but most of the people will do either a double barrel stoma, will bring out the transverse colon as a distal stoma, either a double barrel or a separate distal stoma, or some people would like to do anastomosis and bring out a proximal diverting stoma, or do an anastomosis and leave it. Because everything is, you need to justify each point and you can justify. I
Yes.
would have preferred doing anastomosis, not bringing out a stoma. For the only reason is this patient is developing cirrhosis. What happens when you create a stoma? There will be a
So
lot of
there is
peristomal.
collaterals develop.
Continue
That
bleeding.
can bleed. Yes.
Yes. It depends on the patient's general condition, hemodynamic, and the expertise which you have. You can go ahead and decide. But whatever you say throughout your presentation, you haven't been able to justify and stand by your statement which you made. In exam,
Yes.
what we are looking at is, are you able to justify your statement? Correct?
Yes, sir.
All right. And your terminologies which you use are pretty vague. You always required one of us to give you a hint and then you move forward. So you need to use precise terminologies, which are medical terminologies, not to use vague terms.
Yes, sir.
Okay?
Okay.
Good. Dr. Anand, please.
Yeah, very, very good. You presented well, and don't accept all the points what the examiners. The question is asked just to lead you or for you to substantiate your knowledge. Just take it. Fine.
Okay. Good luck.
Yes, sir. Thank you.
Arun, I think there is scope for a lot of improvement. Right, your presentation is okay, but the question is, what I observed was that you are wavering too much. You're not sticking to a viewpoint when you're present. When the examiner questions you, you have to defend if you say or if you're taken a point. But I found more often you are wavering from one to another. So it didn't give me a confidence that, okay, you know the subject and you know your plan of action with clarity. Right. I think there is a scope for a lot of improvement yeah, in this your presentation. We have Dr. Shastri, Professor Kapoor, and TD. I think TD has.
He had to go to OT, sir.
Yeah, I know. Professor Jaswant sir also is there.
Good morning, Pradeep. Good morning, VK Kapoor here.
Good morning, sir.
We are already late, but one point I make that in the beginning was that history of syncope or unconsciousness was a predominant part of the history. Yes, HCC can explain it by causing hypoglycemia or a bleed, but I would also like to keep a hormonal tumor in mind, and that is where I would bring neuroendocrine tumor and adrenal into discussion. And at one stage, the student said that since there is no symptom of a primary, I would not like to consider metastasis. That is not correct. Many of the primaries would be clinically, and it is only the metastasis which is seen. So in the initial phase, at the discussion point after history and examination, I would still keep neuroendocrine tumor and adrenal as a possibility. I missed the abdominal examination part, but whether it was mentioned or not that the renal angles, whether they were full or not, whether the tumor was bimanually palpable, and if not, whether it was palpable, because an adrenal lump would give the same findings as a renal lump. There are a few other small points, but I would skip them. So students, please send me a mail, vkkapoor.india@gmail.com, write liver in the subject of the mail. Thank you.
Okay. Professor Shastri.
Yeah, I'm here. I think it's a little late. Most of the points are discussed. Don't get disheartened, Arun. It's a little complicated with the complication appearing later, and you have to take spontaneous decisions on the spot. So it becomes a little tough. Stick to the principles and you will do well. I think you have the basic knowledge. Just concentrate on whatever your examiners have pointed out, and be a little firm in your convictions. Don't waver around. Don't agree to whatever they say immediately. Try to support yourself. These are the few things which you have to practice, and this would come with practice. You've done fairly well. Enough, more than enough for a pass. Okay.
Yes, sir.
Yeah, definitely the case is a very tough case for you to judge. Huh? So that is acceptable. You did well.
No, nothing much to add, sir. They already discussed.
Like Arun, TD, any last minute comment, TD? I think he was in the theater. So then we'll wind up, sir. Naimesh and Anand.
Yes, sir.
Thank you, Naimesh. Thank you, Anand. Thank you,
Thank you,
Arun.
Thank you, sir.
And TD and other faculty as well. Thank you.